Thank you very much, Rupak. Uh, for an anterior segment surgeon, for a cataract, after a cataract surgery, the the worst catastrophe that can happen is endophthalmitis. That actually puts you down for 3 or 4 months actually. So if one end off is there, then for 3 4 months you become so much psychologically disturbed. So enemy at the door is bacterial endophthalmitis. How do you classify it? Infectious and non-infectious. We are basically going to speak about infectious post-operative endophthalmitis. Based on etiology, it could be bacterial, fungal, viral, parasitic, etc. We would be discussing more about bacterial endophthalmitis now. It could be acute post-cataract surgery or even chronic or slowly evolving. Post-intravitreal injections. Now, sir was telling about a lot of intravitreal injections. Post-intravitreal injections also it can occur. Blood-related, post-traumatic, endogenous, these can also occur. Post-surgical bacterial endophthalmitis generally occur within 6 weeks and incidence is about 0.05 to 0.2%. The risk factors are PC rent, IOL without heparinized surface, patient is immunosuppressed, diabetes is actually a type of immunosuppression, wound dehiscence or leak, and clear corneal incisions. Other post-op causes like in post-pars plana vitrectomy or penetrating keratoplasty or trabeculectomy or secondary IOL placement, in all these situations also it can occur. If you look at the organisms, the vast majority would be coagulase negative staph epidermidis. And we also can get Staphylococcus aureus, which is the more pathogenic variety, and Streptococcus. Gram negatives and other bacteria are rare in acute bacterial endophthalmitis. In chronic bacterial endophthalmitis, you get Propionibacterium, acnes, etc. as the causes. Clinically, patients would usually present with pain, redness, decrease of vision, and on examination you would have decrease of vision, swollen lids, chemosis, congestion, corneal edema, hypopyon, vitritis, and hazy view of the retina. So what are the possible situations that one can encounter? Endophthalmitis on opening and in the first post-op day may be secondary to a very virulent gram-negative sepsis. And more commonly, it will be endophthalmitis on a follow-up. Initially, there was a very good visual recovery, which is very important, followed by a drop in vision is what we should look at. Or it could be a late onset end-off. In the first post-op day, the red alert features would be pain. There will be much more pain than in most of the other patients, reaction and decreased vision. Always try to admit these patients and don't trivialize it to say that, I've seen a lot of reactions like this, let us put steroids and come back after a week. That is an attitude which anybody should not take. Admit patient, because subsequent follow-up in hours, because in the first follow-up, first day, you are having a significant reaction. This could be a very virulent organism. This is between 10 a.m. and 2 p.m. The change is very, very dramatic. The second situation would be an initial good gain in visual acuity after cataract surgery, but on follow-up there was a decrease in vision. Again, increasing pain, increasing symptoms, worsening reaction, worsening visual acuity is what is to be looked in these cases. When you look at reaction, surgeons' own cases are as gold standard. You should know what reaction you actually make. And so for each person it may be different, and familiarity with your reaction on slit lamp is very important. Otherwise, if you first see this patient on the slit lamp, and any patient, if you see there will be some cells post-operatively which we may think that it is a problem. Decreased glow on distant direct ophthalmoscopy is quite sensitive but has very low specificity because a bleed can also cause it. But exudates, yellow exudates in the vitreous cavity has very high specificity. But you should always differentiate with sterile post-operative inflammation seen after like a TAS or a retained lens matter or excessive iris manipulation, etc. So to sum up, how to differentiate between inflammation and infection? It is extremely difficult, but there are some features which we can look at. PR inaccurate or no PL usually doesn't go with inflammation. Okay, pain, it will be more intense with infection, less intense with inflammation. But you see in the endophthalmitis vitrectomy study group also, there are about 25% people who did not have pain. And vision drop can occur in both, chemosis can occur in both, but more chances in infection. Hypopyon also can occur in both, but more chances with infection. If you look at fundal glow, will be grossly poor or absent in an endophthalmitis, mild decrease in inflammation. A focal infiltrate on the wound is a very characteristic feature, may occur more commonly with infection than inflammation. Vitreous cavity, vitreous haze, if it is there, more chances of infection. Color of exudates being yellowish versus whitish, yellowish is more chance of infection. So how to proceed with the injection? If there is no hypopion, if there is vitreous exudates, and check for vitreous exudates. If the pupil does not dilate, and if the slit lamp exam shows a lot of inflammation, and if the vision is less than 6/60, towards injection. If there are vitreous exudates, then generally you plan that vitreous endophthalmitis and plan an injection. When in doubt, err onto the side of infection. Management is about ultrasonography, first of all to find out any vitreoretinal relationships, and then you will do a culture and sensitivity. Basically you can use lid, conjunctiva, aqueous, vitreous, etc. Best to get from the vitreous at the time of injection. Culture and sensitivity should not be the diagnostic point. It should be, you should do it because at 2 days you will get which is the organism, what is the sensitivity. But our initial treatment is not going to be based on that. Basically you have to do the lab test. Many of these patients may have uncontrolled diabetes as well. Intravitreal injections is the mainstay. Vancomycin and ceftazidime is the mainstay of treatment initially. Amikacin can be considered if there is a gram-negative infection which is there. Some people give adjunctive intravitreal steroids, and then adjunctive topical treatment like steroids, antibiotics, cycloplegics, etc. can be given. Vitrectomy is to control, eradicate the infection, manage complication and restoration of vision. These are the questions that we have to ask. Whom to offer? Endophthalmitis vitrectomy study offered hand movements at 1 meter or more or less. Those are the patients who underwent the vitrectomy. Severe infection at risk of panophthalmitis, corneal involvement, intractable secondary glaucoma also can undergo infection. When to do? It should not be too late. It need not be too early. So the window of activity you basically have to decide. Immediate vitrectomy when there is total absence of red reflex and it is not responding to intravitreal injection, inaccurate projection of rays, ring infiltrate on the cornea, etc. Now these are some of the videos of vitrectomy. So here you can see that this is a exudate which is covering the pupil, which we usually tease out with a MVR blade, and you can see that now this area has become clear so that we can see inside. In this case the infusion cannula is not seen inside, so I made a 6 mm 20 gauge infusion cannula and started the procedure. And here you can see that this is a vitreous exudates which you clean up, and by the end of surgery you would have a clean surface of the retina. If it is a more severe endophthalmitis like this with more vitreous exudates, you cut, you do not go very close to the retina initially, and once you slowly clean up, then you can see that the retinal surface and the vessels are seen. These are, sometimes exudates keep on coming. It is always a very good idea to take culture and sensitivity while we are taking a vitreous sample. If there is a retinal detachment or anything like that, there is a tear here in the periphery, then you have to do an extensive vitrectomy and use PFCL and silicone oil at the end of surgery. Perioperative problems, you could have edematous cornea or visualization problems, etc. Sticky vitreous without PVD, inflamed necrotic retina. Epithelial edema prevents your visualization. You can remove the epithelium. After closure of sclerotomies, check the corneal wound again. At the end of vitrectomy, I generally give an intravitreal antibiotic injection. So these are some of the results that bad endophthalmitis, you have at about 6/36 vision in the end. But some cases can be like this. At the end of surgery also, you will see that the retina is attached but with very poor functional prognosis. To conclude, we should always know that prevention is better than cure. Index of suspicion has to be maintained once we suspect ENDOF. Explanation to the patient is the most important thing in the management of ENDOF. And urgent intravitreal injection, timely referral or timely surgery, realistic results to be explained. Thank you very much.